Good morning, Patrick.
Good morning, Carol.
Nice to see you this morning.
Yeah, well, it should be a good day.
Good. You have some nice weather up there in Spokane?
For now, yeah, it's very sunny, kind of cool, but it's supposed to get rainy sometime tonight.
Yes, it is.
So I'm not complaining.
Yeah, it's supposed to be, there's a rain forecast for the whole Northwest, really, from the coast and from Oregon, sweeping across the state into Idaho. So it's going to be very rainy, and we're hoping that it helps with the fires.
Yeah, I was talking to somebody in Yakima yesterday. Hi, Sandra. You're there, I'm sure. And they said it was still smoky. We don't have smoke anymore.
Yep, still definitely very smoky. I mean, the fire is only, 20 minutes away. So.
Oh, that's right. Yeah, yeah.
We're just really close. So there's not really a way to get around it. Although this morning, I will say it's probably one of the clearer mornings so far, but a lot of times with the cool air, now that it's getting cooler, the mornings aren't so bad, and it's by mid-morning to lunchtime, it starts to kind of get hazy again.
Yeah, that's right.
We had an article in the Herald this morning that said we've had 6 days of good air quality since August 3rd.
Whoa.
Yeah.
Yikes.
Prefaced with a photo of the kindergarten class in Natchez, which is probably the closest community to the fire. And they finally had their first day of outside play recess since school started. So,
oh, that's rough.
It's rough, but hopefully this weekend's rain will help them. The fire's, I think, 25% contained now. So, I mean, they're making grounds every day.
Yeah.
The weather's helping. The wind is not, but the cooler weather is.
Yeah, I forgot how close that fire is to you all. That's in the Upper Valley anyway. That's tough. Well, that we can add to maybe next year some of the long list of conditions we need to address in health. Is PM 2.5 and everything that comes with it. Well, we've only got a few people on the line right now. This is Patrick up in Spokane, your facilitator for today. So we'll wait just a couple more minutes, and then we will start with the crew that we have, and I'm sure that many more will join us. So stay tuned. Well, good morning, everyone. Why don't we get started? It's a couple of minutes past the hour, and we do, as usual, have a full agenda. And I do think, given the RSVPs that we have received recently, that the number of people on the call in the meeting will certainly go up in the next few minutes. But let's nonetheless start with our overview of what we intend to do today. And this is about community information exchanges. We have touched on this topic a while back at a leadership council meeting, but we thought it would be very important to take a deeper dive today, in part because this is being proposed by Greater Columbia ACH's staff as a point of activity in the near future, that is 2022 and beyond. So before that were to take place, we thought it would be great to get feedback from the Leadership Council about your thoughts on a community information exchange in Greater Columbia's 9 counties. Now, community information exchanges is really a burgeoning topic and a sort of a nascent idea, and it may mean different things to different people. So we have as you can see here, we have 3 folks weighing in about their view of community information exchanges. Skylar Young from Site Savvy, Michael Arness from the HCA, and then Gina Morgan from King County's Healthier Here. And as always, we hope you will be filled with questions after you hear some of these presentations so that we can have a good dialogue before we break. So that's the lineup. And since we're still meeting remotely, we can't go around the table and say something about ourselves and our organization. So we just have to take advantage of the little participant button, so you can see all who's in the room with you. And I think you'll be happy to see that there's a lot of people who find this of some value to tune in. You can see here for, as we always do with Leadership Council meetings, they will be available, the recording will be available in just a little bit under resources on the website. And this short survey at the end of our meetings is actually a bit valuable, more than a bit valuable. It's used in how we plan future meetings. So if you wouldn't mind just spending 50 to 60 seconds to do that, we would greatly appreciate it as we come close to the 11:30 hour. All right, so let's shove on. And as we have been doing now for many meetings, we would like to acknowledge the land that we are having this discussion on. And that's our land acknowledgement to the Yakama Nation. And I will ask for somebody among the near 40 people on the line, if you would raise your hand and read the acknowledgement. So is there a volunteer to go over those few lines on the screen? Any hand up? Stacy, do you see a hand up?
Kirk Williamson said he would do it.
Okay, Kirk, that would be great if you could do this.
We should take a moment to acknowledge the land on which the Greater Columbia ACH residents live, work, and play. It is the historic homelands of the 14 confederated tribes and bands of the Yakama people. The Yakama people remain committed stewards of this land, cherishing it and protecting it as instructed by elders through generations. We are honored and grateful to be here today on their traditional lands. We give thanks to the legacy of the original people, their lives, and their descendants.
Thank you, Kirk. That was very good. All right, let's start with our Executive Director, Carol Moser, doing a summary of what you have said so far, you, the Leadership Council, via a survey that we undertook 2 or 3 months ago, I believe, maybe a little longer than that. And we thought it would be good to start reviewing what we seem to hear from all of you about a community information exchange. So Carol, the floor is yours.
Great. Thank you, Patrick, and welcome everybody to our September Leadership Council meeting. In April, we actually had Innovacer present on their CIE, their digital exchange platform, and it was very technical. But we did at the end of that Leadership Council meeting ask for you guys to take a quick survey on what you thought were important features of a survey. So we are going to just review those results today. So Stacy, go ahead and get to the next slide. So there were 37 responses, smattering across the GCACH region, with the largest responses coming from Benton and Franklin and Yakima counties. Next slide, please. We also had good representation from the different sectors. So as you can see here, public health and healthcare, FQHCs, behavioral health and SUD, and community-based organizations were really well represented, with other representation coming from skilled nursing facilities, public safety, transportation. In that other column, you can see as Stacy scrolling down, some of those other sectors that were represented. In terms of what you thought the level of need for a broad community information exchange in your area was, there was a high need according to 70% of the respondents, and a moderate need about 20% of the respondents. In terms of the features, if you'll scroll just to the bottom, Stacy, you'll see that the dark orange represents a high need, I think. Yeah, very important need, and then the teal is important. So you'll see as you scroll back up that there was a high need for a resource directory, community resource directory, referral management. I think resource directory was the highest need. Referral management was very important and important. An integrated system into the EHR. I know you can't read the full description of that answer, but that's in the responses below. Integrating the social needs. So some kind of an assessment that was integrated into the CIE was really important. Personal health information, and privacy protection landed as the topmost need of any kind of a community information exchange. So we know that a CIE that shares shared care plans and information between organizations and agencies is going to have a high level of protection for that patient information. If you could just kind of go, yeah, let's look at those statistics, please, Stacy. So you'll see that referral management received about 46% as being very important, 38% as being important. The CIE was very important and important. I think that was our highest score. Systems integration, again, another really important need. So you can kind of see through privacy protection really landed on top, reporting and analytics. So this gives us a really good understanding of the types of features that you all believe are necessary. However, I think after today's Leadership Council meeting and after you hear Gina Morgan's presentation, you're going to realize that a digital system is only as good as the infrastructure that's on the ground. And so that's going to be really important as we move forward to make sure that that CIE fits local needs. Next stat. This was an interesting question about the other features that you would like to see in a potential CIE. I'm not going to read all of these, and we can certainly send out a survey to all of the Leadership Council. There were some people that felt like the ACH shouldn't be in the middle of this. There were some people that said that the CIE should cross boundaries and county lines so that you could share across the region. The ability to protect privacy, a system that integrated with EHRs. You can see response number 18, a system that will integrate with all of our different EHRs. My experience is that many products that I've seen have great marketers, and they say that they can do everything to meet all the needs of, and then once the product is purchased, the providers realize that the marketer was not completely honest in the capability of the product. So these comments are going to be very critical as we figure out what kind of a CIE system that we want. There were some questions that weren't answered. I'm not exactly sure why, but we had several, including this question: what capabilities would you need or should be included to incorporate a CIE into your work? So we didn't have any responses to this question. I think there were a couple other questions that we didn't get responses to. This one: give us an estimate of the level of funding your organization would need to implement a CIE. So not sure what happened there, but some other thoughts about a CIE in the Greater Columbia region. So great suggestions of including the fire and the police, the school systems, quick connections to individuals and services. If things get to, here's question 14, or response 14, if things get too complicated, it will lead to difficulties for people to navigate. We need to be thinking about a system that can be navigated, those who need it most, in terms of level, reading, literacy, language appropriateness, and talking texts. Some people were grateful that this work is being started. Some people recommended that a statewide system is set up, and that it's not different in every region. So again, the kind of an advocacy for a statewide CIE. You know, providers do not get administration funds to do all the data entry. We are currently required to do it, and expensive and time consuming. So again, concerns about how much is this going to be costing to report into the CIE. And then traditionally resource guides, I'm on response 19, have been difficult to maintain. So as you know, Greater Columbia ECH has been contracting with WIN 211 and our local health improvement networks to make sure that the WIN 211 resource directory is up to date and has the resources that you need for your local communities. So as we look forward, how do we maintain that level of accuracy in the resource directory, which may or may not feed into that CIE? So that was the quick overview of the survey. And I think after today, it will be interesting to see how many of those questions that can be answered through the presentations. Thank you, Patrick.
Thank you, Carol. I looked at some of those comments, and I'm hoping that in our discussion half hour at the end of the meeting, that some of those can be raised by different folks, and we can have a dialogue around them. Let's then jump into our presentations. As we have 3 people, as I mentioned. The bios are below each of the picks, as you see here. And we are going to start with the person who's been in the middle of developing something that might be very akin to what ACH, Greater Columbia ACH has in mind. And this is Skylar Young from Site Savvy. And so we thought it'd be good to have this, call it a case study, and some of the technology behind that particular effort. So Skylar, you've got about 25 minutes, I believe, and the floor is yours.
All right, thank you very much. Can you hear me okay? Let's just make sure the mic is working.
Yes, we can.
Good.
Thanks, Skylar.
Okay, awesome. So yeah, my name is Skylar Young, and I'm a developer. Mostly, I've worked in open source software and also hospital software for the most part. So it's been kind of interesting when Tim Sullivan, the director of the Washington 211, came along and said, we want a website. And then he was like, we also want a search engine. And gosh, it would sure be nice if it integrates with, EHRs someday. I was like, I might be able to help with that. So but man, it's been quite the journey, let me tell you. I'm not from a social services background, so it's been kind of a fire hose of information learning about this amazing industry and the services that organizations like the GCACH provide. So a little background here. Tim Sullivan, like I said, wanted a search engine for human resource data. In 2018, I think it was, their prior vendor got taken over, and it became cost prohibitive to continue. So we tried rebuilding a new one. And the product today is actually the complete third iteration. It's been it's been a wild ride trying to get one that works and works well. And we've had to overcome some pretty extreme technical challenges, particularly around geographical data like service areas, to get those to be very precise. And I'll talk about that a little later too. But we're here. We have the product. The search engine is live in search.wa211.org. And I'll give a quick demonstration of what that looks like. So right off the bat, when someone shows up at the search engine, they're going to go to the search field, and it has suggestions. These are backed by taxonomies. So we're actually doing a taxonomic query against the resource data using the AIRS 211 taxonomy. And these needs were put together in collaboration with Tim and also Hannah from Crisis Connections. They're looking at the data from the call center saying these are the most common needs. So we put this list together. And there's a little bit of a search radius in case you're only looking for local resources, but you can also just look for anything that you're in the service area for.
So Skylar, sorry,
yeah.
This is Carol. Are
Hi,
you
Carol.
going through your slides? Who's managing your slides right now? We're just seeing your very first slide.
That is because I forgot to share my screen.
Okay.
I was about to ask Carol, thanks for.
No problem.
That is why. And it actually says at,
I think you have to stop sharing, Stacy.
yeah. There we go. Thank you so much, Carol.
You're welcome. There we go. Now we can see it.
There we go. So we have suggestions. And again, these are all based on actual needs in our area in the state of Washington. So we select, I need food. We select, are we looking locally or not? And then we can put in our area, or we can just hit the crosshairs, and location aware devices will automatically populate that for you. Particularly great for people who have smartphones and that sort of thing. And it pulls back all of the resources. We can see them on a map. We can call, look at their website, and get directions. I really love this feature. It uses the Google Maps API to find out how to get from where I am to where that resource is. And because it's Google, it also allows you to filter by transit and other types of methods like that. So you can use local transit to get to your needs. So this is actually one of the more popular features that we find people really resonating with. If I drill in for more information, then we're basically just going to pull back everything that we have in the database for these resources. And then we can go back to the list. We can also print and share these. So email, Facebook, Twitter, print it off. And I'd also like to point out that the URL actually is unique for every resource. So anyone who's rolling a search engine like this has some SEO value. You might turn up in search results for these resources. So you're helping those organizations actually get exposure, which is really cool. And it also means that you can just grab this URL and email it or text it, anything you want to anyone, and they'll be able to just click on it and go straight to that resource. The same is actually true for these search results. The whole query for what we're seeing in the results is unique in this URL. So you can share this or text it, whatever you want to do. And someone can click on it and immediately see the same set of results that you pulled up for them. If we go back to the front, we can actually start typing. And this is pulling back, again, the taxonomies that match what we're typing in. So a really easy tool for finding the taxonomies you might be looking for. And this submits a taxonomy query. On the flip side, I could say, you know, I just want to do a keyword search. So let's look for anything that has food, you know, in it in the Yakima area. And I'm getting all of those back. It's about 35 results for that. So this is a very simple tool, but I'll talk just a moment about what's happening behind the scenes because it's pretty impressive. We're also creating this taxonomy kind of like category group so people can see at a high level what you offer, and this could be used as a bit of a guided search. So yeah, behind the scenes, we're using a super fast search engine, so results are very fast. And we were just talking with Nebraska 211, and they actually brought in their technology guy, and he got very excited when we talked about how we're doing service areas. We actually have a couple agendas going on. When Tim asked us to make this, he was like, look, I need this to be something that other 211s could use. It needs to be something that my partners could use. And I also want to start pushing for a standardized data schema for human resources. We settled on HSDS. So in order to run this application, we import whatever you've got into HSDS schema. And if you need help doing that, we provide all of the service to do that. So it's not a huge lift for any other organization, but we create that transformation and we store it in the database in HSDS, which is really handy because then at any time in the future, if you want to have your data or share your data in that common schema, you've already got it ready to go. And then we're also sanitizing the service areas, which we discovered is an absolute nightmare. It's mostly just text matching strings, but there could be duplicates, there could be missing ones, there could be all kinds of problems with that. We sanitize it and we turn it into actual surveyor grade geoshapes. That's a little crazy, but it's what we do for every single one. We wrote a special service just to do that. So when someone goes to filter results based on the service areas that they serve, it is absolutely precise. You are a point in space defined by geocoordinates, and then every service area is defined as a shape on the globe. And we're just checking to see which shapes do you fit into for the services that you're looking for. Yeah, the tech people have been flying off the handle on this. They get pretty excited, which makes me happy because we spent a lot of time making that happen. So yeah, it's so simple. It bolts onto whatever you've got. It doesn't replace any existing infrastructure. Now, my company provides a service for this, and we can manage this for many people. So for example, this is Washington 211's main search. But one of their partners came to us already and said, we'd like our own branded search portal that just has part of 211's data. They're called TeenLink, and they serve teens and at-risk teens, youth, and adolescents, mostly in the King County area, but I think it's really statewide. They've been publishing a booklet of resources for years now, and their board has been asking them to create a similar resource, a matching resource that's online. So we took the same piece of software, cloned it, added their branding. It's actually built to do this really fast. It was super fast to make this instance for them. Like it took a few days. And their list of needs is customized to their audience, to the teens. And we'll go ahead, and in their case, they're probably over more like in the Tacoma area or Redmond or something. And it will pull up resources specific to what they provide. So we do have 2 resources here. So what's cool about this is that it's using 211's data under the hood. So TeenLink doesn't have to worry about putting in resources, managing the resource database. They don't have to worry about having developers or anything like that. They didn't have to replace their website. We just said, tell us which parts of 211's data you want to use. And then we put this together. We branded it for them and put it online. And then they just link to it from their website and from their booklets and emails and things like that. It's a custom URL for them. So we can do that for anyone. And that's the really exciting piece. Anybody in Washington State who wants to share resources with their target audience can do it using 211 data. And we've watched 211 work with local organizations. They're very good at helping keep that data up to date and managing the resource management side. And then we have a service here on top to help access that data in a really useful way. That's the gist of it. I'll also say it's an important piece that this is open source software now. We just finished last week taking our whole code base open source. And that's a statement that we want this software to be available to everyone and to perpetuate and not to be stuck in the silo of one company. I'm definitely trying to get some customers to run this service so we can fund more development. But at the same time, we want other developers to step in and run this for their own nonprofits and organizations and contribute to this with us. And so, yeah, so it helps prevent lock-in. You'll never be stuck in one company. And because it's all standards-based, that just makes it even easier to find other developers to work on it and to build a larger community than just one company.
Skylar, can you tell them how that they can check their information to make sure it's accurate and if there's any changes and how they would make any changes to it?
Yeah, absolutely. So Washington 211 actually handles that themselves. We actually want, it's on our roadmap to add a more seamless interface so you can just literally look at your resource and then say, hey, I have some feedback or an update for this. But for the moment, you actually go to WA211.org as a provider, and you can either list your resource or you can update your resource. They're both really simple web forms that you fill out with your information and send it in, and they take care of it for you. That was a great question. Does that answer that question?
Yep, that was perfect. And then there's one other question. Can you show them how they can favorite different resources so that?
Absolutely. So it's free to sign up for an account here. And it's just a technical thing we had to do because if we didn't have them sign in, then we wouldn't be able to keep your list between things. But there's no tracking of data. There's no sharing that information. But when you drill into a resource and you log in, then you can actually hit a favorite icon. Now let's see if I can actually do it because I have been jumping in and out of this, making and deleting my account so much for testing. Let's see. That I'm not even sure at this exact moment that I have a working one. I should have thought of that.
Sorry, I didn't mean. I wanted to be, that is an option so that they can have a list already stored and then they can print it off for their people they work with daily. And
yeah, it's true. And actually what our developer is working on right now is the ability to, gosh, I don't know if this is going to work. The ability to have lists of them. Oh, sweet. It worked. Look at that. We're really lucky, guys. So I just, as soon as I log in, you can see it switches out. You can say sign out, or I can look at my favorites. And here they are. Here's just a few that I've tested. And if I go back and search for some more resources, I'll have the option to add some more favorites to that list.
There's another question in the couple of questions in the chat. One of them was, what would you have to list each service individually? Why would you have to, what you have to list each service individually? Example, substance use, teens, counseling, adult recovery, and support adults.
Oliver, can you clarify your
maybe
question?
Yeah, I don't quite follow that. Let's see, example, substance.
Sorry, typos. Autocorrects. So no, my question was, could you just do one listing for the agency, or would you have to list the agency plus each service? So for example, if we were just doing teens and family is one area that we work, adults is one area we work. We do recovery supports for adults. We do counseling for adults. We do family supports. We do recovery support. So we do kind of an array of things.
Yeah. Yeah. So there's a couple ways I think I can approach that question. First of all, just to clarify, this interface is basically normalizing services at locations. It's just how we're doing it right now so that we can plot everything on a map and show people how to actually get there. The agency information is included in the database, and we've had some requests that make an agency search as well, so that you could search for specific agencies and then pull up all of their services and locations. We haven't had enough interest in that to prioritize it super high, but if that's something people want, I'd love to hear about it. But you always see the agency information in the records. You can also search by keyword to find agencies in a particular region, for example, like Salvation Army or something. But there's another answer to your question, which is that because every search and resource in the system has a unique URL, and because you can also build queries, taxonomy queries that say, just return all of the results that have certain taxonomies. We've seen like Crisis Connections on their own website and other places kind of make their own kind of starting point for these actually. So for example, if Hannah was like, I need a button that is just resources for substance use / teens, as you said, then she can decide which taxonomies correlate to those resources and then just create a query for it and a button that goes straight to that list of resources. So that's all that's happening behind the scenes with this list of categories here. Each one of those is a link that just goes to a taxonomy query, and it can be one or multiple taxonomies. So yeah, there's a lot of ability to create kind of your own custom interface. Does that answer that question for you?
Yes, it does. Thank you.
Thank you, Oliver.
Sorry to interrupt everybody.
No, you're fine. The second question is from Kendra. And this is looking at something that information that may come and go, time limited information. Is that able to be managed by your software?
Yeah, so the key to this is that we're not managing the resources. 211 is managing the resources. And again, what I've seen anecdotally is that they're very good about making resources available or making them unavailable depending on the season. Our system is queuing off of their database ultimately and updating daily. So we see when a resource is no longer available or should be displayed, and it automatically disappears in about 24 hours since we're doing daily imports. So yeah, you would reach out to the 211 call center and say, this resource needs to come down now, and then they would yank it.
Okay.
And is there a place, hello, it's Kendra. Is there a place specifically for events? Because I feel like that is a hard thing to manage. There's so many things going on, and somewhere that could be found, like a calendar feature.
Yeah, so that's actually been requested. I only know this because I also manage 211's website, and they tried to create an event system at one point. That is, as you say, a whole different kind of issue and a very different type of data to manage. So it's not something this system does, no. We're really just focused on the resources in the database and how to help people find help, basically. But events, I think, should be run separately, unlike calendars and stuff.
If you were to, let's say, make an instance for a different organization that was more events-based, then maybe they did host a lot of events and that was their main service.
Yeah.
Would you be able to create an app for them that functioned, that's purpose was to maintain events?
Yeah. Careful, right? You're talking to a software developer, like everything's possible. We've built, what I'll say is we've built a lot of event systems for nonprofits for sure. Actually, under my sister company, Sanitizing, we do just websites, mostly WordPress based. And so I think we have about a half dozen people right now that have event calendars that they run and get subscriptions to and things. There's also a lot of really great third-party solutions for that I've consulted with people to find and implement. So there's definitely a lot of solutions for events, but it's outside the purview of this particular application.
So Skylar, the next two questions really may relate to 211 and not you, but they asked the question about the listing of clinical resources, not just community-based organizations, but folks in physical, dental health. And yeah. Is that something that is on part of this particular piece of software?
So as far as I know, 211 does actually provide resources. They include a lot of resources, in fact, for that sort of thing. Let's see what we've got. So we don't have mobile dental care here in Yakima, which is no surprise, but what I've seen in the database is a lot of clinical facilities included.
Okay.
So the answer is like, yes, pretty sure that's already in there. And if it wasn't and you wanted it in, then I believe they'd be happy to have it there. So That is, as you say, something to probably clear with Tim or Hannah for sure. But we've seen a lot of medical resources in the database. So I think that's something that they're actively pursuing.
And that would include behavioral health?
Definitely. Pretty sure about that one.
And where he showed you how to update the resource or check for your resource also is the same place you could add a resource to.
Exactly. In fact, that's the form that I pulled up right here. This is the one for adding a new resource to the database. And also if you have spreadsheets, if you have hundreds of records that you need to add, you can work with them directly to get those bulk imported and not have to sit here and go one at a time. So yeah.
So the next question, Skylar, and we're gonna probably have to break here in a minute or two, is do you have a search field that looks at the type of an insurance a visitor may have and use that to guide the person's search?
Yeah, that's a great question. So that's going to be an eligibility basically, or like it falls into the, which field would that be? There is in fact an insurance field, or like a requirements application process field in HSDS. So the question is, does 211 have all of that data like filled out in a way that we can filter by? And the answer is not completely. So we're building out advanced search functionality. That's on our roadmap. It's one of our top things we'd like to go for, but it need the data to filter on. So for example, we'd like to filter on age groups, focus populations, time of day open, so scheduling, eligibilities, really any eligibilities. And we've been looking at the open eligibility project to kind of start pushing those standards as well, maybe, and build that out. So if the data has the filters and then 211's database is giving us that data, then yeah, we can start filtering on it. That's one of the areas I would most like to start developing in.
Okay, so the short answer is not yet, but perhaps.
Yeah, but we are displaying any text-based information. So you can't filter on it, but you can see it.
Okay, thank you. Are there any final questions for Skylar? Well, then if not, I'm sure we can reach you in a fairly easy manner through the staff of Greater Columbia ACH, right?
That's correct. And I'm throwing our website in the chat there as well. Just connect211.com.
Okay.
You can reach us there. Thank you so much. I appreciate this opportunity.
Thank you, Skylar, for taking the time to appear before us today.
Thank you.
Okay, next we're going to move to sort of a high level look at community information exchanges in the state of Washington from Michael Arness, who has been with us before from the Healthcare Authority. And as you heard from Carol, there seems to be some interest by the Healthcare Authority in a statewide community information exchange. So maybe Michael will be talking about this or other aspects of a CIE from Olympia's perspective. Michael, the floor is yours.
Good morning. Thank you very much. Hello, Carol and members of the board. What I wanted to talk with you about a little bit is where the Healthcare Authority is going on CIE, but first of all, how we're attempting to fund some of it. And thank you. It is at a very high level. And we have 3 funding options that we're looking at for CIE, for Community Information Exchange. And I think what that does is it reflects how sincere and how serious we are about attempting to find funding to do something more at a statewide level. And if we could go to the next slide, each one of these is going to take a little bit of explanation, but first and foremost, of course, is the American Rescue Plan Act. And when that act comes out, and of course, I think most of you know this is the latest coronavirus act for support across the US. But when this act comes out, municipalities like the state have options to use the funds that are in the act. What we then have to do at a statewide level is to, as an agency, as the Healthcare Authority, is to make our case, our rationale for why we would like to use the funds within this act and those funds that have been appropriated to the state, so that the money does not come to us straight from the act. It goes to the state, and then there are discussions about how best to use that money. And of course, what we've done is talked about community information exchange and with the Office of Financial Management, the governor's office, and some of our sister agencies, and let them know that we think this is a good opportunity to procure money for community information exchange. And it would be really one of the best and most direct ways to fund the interest that we have in working with ACHs and working with other municipalities and partners across the state to try to form some kind of a statewide system so that each community could have some form of a community information exchange service. So there would be some participation. This does not have to be the same system across the entire state, but it would. What we're looking to do is to make sure that we have functionality within each community across the state, so that those community-based organizations can have some way to talk to each other when they're trying to perform the services in every community. We have made that request, and it's being evaluated. We don't have the go-ahead to use the money in that particular form yet. And a lot of that has to do with so many competing requests to use the funds. The second and third options are actually quite similar. The first is that we're in the budget process right now with the state for requesting the governors to be inclusion in the governor's supplemental budget. And we would put forward what is called a decision package. And that's simply the way the state agency makes a request to become part of the governor's budget. That package has been put forward. Carol, I can send that to you now because it was posted yesterday by the Office of Financial Management. It does not mean that it's in the governor's budget yet. It means that it's been, again, put forward. So there's a lot of competing decision packages across the board, not just for information technology or community information exchange, but really the full breadth of the governor's budget. But it is a high level, it's a highly prioritized request from the Healthcare Authority to be included in the budget. Of course, at any minute, if we were to receive funds from the American Rescue Plan, we would be funded. And so we would simply pull the decision package and say, please ignore it, no reason to go further. We've received the funding we need. The second or the third option for funding is what we've been working with all of the accountable communities of health on, and that's the Medicaid Transformation Project Waiver. And this would be the Section 1115 Waiver Renewal. And I think, as most people know, as we are preparing a 5-year renewal to submit to CMS, we also have to request this money from the legislature. I think, as most people know, the legislature authorizes the funding. Even though it's predominantly local and federal funding, the legislature still must authorize the funding for any waiver that we do. And as we are preparing to submit a application for renewal to Centers for Medicare and Medicaid Services, CMS, we are also preparing our rationale to the legislature for why we believe the money should be authorized. And so, of course, this goes forward in a decision package as well. So this has many items in it. Carol, this is what I sent to you yesterday. And one of those items is a community information exchange decision package. In fact, it is the same decision package up there in number 2. And what this is just one more contingency, because if we cannot get the decision package that is straight away for community information exchange, we'll come back and say, there's another way to fund it. And that's because even in number 3, the funding would be through the waiver then, and it would not start until 2023, and it would be a different funding mechanism. So while they're both decision packages, and the decision package describing the community information exchange functions are identical. The funding mechanisms are not. And so if we don't get one or two, our last contingency is to put forward community information exchange as a decision package to be, excuse me, authorized in the waiver. The minutia of federal and state funding is a thrilling topic, I'm sure, but if there's any questions at this point, I'd be glad to clarify somewhat, but I hope what the ACHs are hearing from the Healthcare Authority is that we believe community information exchange is just going to have to be a foundational piece of IT support for all the work that we're doing in the communities. We need this. And when we are talking with Office of Financial Management about why we are asking for federal money through the Rescue Plan Act, why we have 2 decision packages, we simply say that's how important this is. And we need to get it funded and we need to get started on it.
So any quick questions of Michael on these particular, this particular perspective, this funding perspective? So I'll just ask Michael, that seems to be a pretty rich or pretty secure plan to access a certain amount of funds. Is that your sense that the probability of getting some money for this IT backbone infrastructure will be there in 2023? Would that be it, or earlier?
Let's talk about the possibilities and the risks if we could. I would like to think that the necessity of it would be understood by a lot of people, but and I think sometimes the necessity can. Probably the bigger challenge is all of the different things we're competing against, especially when it comes to the IT area. For example, we put forward number 2 last year as a decision package. And one of the main reasons it did not gain any traction, and matter of fact, didn't make it into the governor's budget, was that there were so many competing IT decision packages and needs that go forward. So the needs are severe. We have legacy systems within the state that are sometimes decades behind being updated or replaced. So a lot of times we can get a lot of agreement that we've made a good case, but that the competition for dollars is just simply overwhelming our request. So unfortunately, I think we're going to have to work pretty hard to get this.
All right. Well, thank you for that assessment. Any other questions on Michael based on this slide? I hear a voice in the background.
Yes, there is a question in the chat. Will this be for all payers?
I think that referred to Skylar's presentation, but I'm not sure.
Oh.
Melissa, do you want to clarify that?
Yeah, no, it actually, I have similar question for Michael as well. I was just wondering, with the community information exchange, is it only for Medicaid recipients, or can other patients such as DSNP, Medicare, or commercial patients also be part of the community information exchange?
Good question.
Yes, and that's a terrific question, Melissa, and very important. And I hope you don't mind me saying it'll have to be figured out as we go forward, because it will depend on the funding. So if it's the way that under the American Rescue Plan Act, there's a better chance it would be for all payers, and also under the decision package with the Washington state budget, better chance of that as well. And that would be everybody's intent, including ours. When we get into the Section 1115 Medicaid Transformation Project waiver, then we have to pay more attention to whether the waiver is serving Medicaid patients. And I would have to reserve any judgment until we could see how CMS actually would respond to the waiver and provide us with guidance. So in that discussion with CMS, after we submit the waiver, we would discuss with them about how broadly we would like to use community information exchange. it would be up to CMS to describe for us in our contract, which we call special terms and conditions, to say precisely how broadly we could use it. So as you go down from 1, 2, and 3, there is a possibility of not being as broad. But I hear you loud and clear. I think everybody would like to see it across all payers for all people.
Thank you, Michael.
Thank you.
Michael, I have a question for you. This is Carol, and yeah, thank you for sending that decision package yesterday. So one of the comments that was made earlier when we were reviewing the survey was the need for a statewide CIE that was integrated, that would relay information across the state around certain, referrals. Having each community have its own CIE, don't we run the risk of those not being interoperable, which has been part of the problem from the very beginning, is that we have all these systems that don't talk to each other, that aren't integrated with the EHR. What is the healthcare authority's opinion on how to go about creating a system that might not be interoperable?
Mr. Jones, would it be okay if we went to the next slide, and we can bounce back and forth? There's only 2 slides.
Sure.
Thank you, sir. Carol, good morning. So this is the slide that we often use to introduce what the healthcare authority is talking about when we say what is community information exchange, because it is a new animal. And Carol, let me talk a little bit, but I will get to your question. So that what you see in the bubbles here is the different elements that typically make up some kind of a IT system that people are calling community information exchange. And so the keys to this is that usually to be a true CIE, you usually have to have at least about 2 or 3 or 4 of these bubbles functioning. Otherwise, your system really isn't community exchanging information. But it doesn't have to have all of them. And if one were to build out all of these, that would be a super functioning system. So then, Carol, to your question about, well, what about the healthcare authority's vision, which does say that we don't think that every community has to use the same system. And if you had the text behind this bubble chart, that's what it says. But what we're looking for is that functionality. And we are looking for interoperability when we perform, or linkages when we perform these services. So what this also goes to is that, working with the ACHs, some of them have invested quite a bit in IT infrastructure that I would say has built out some of the bubbles on this chart. And we would like to let communities continue to use a system that they have built, that they have buy-in on, and that they become familiar with. And we also would like to leverage that investment. There's no reason to try and walk away from that, or to make somebody scrap something and rebuild it in a county or in several counties. The keys to that, Carol, is what you're talking about, is the risk is, can we link the systems through time and make them interoperable? What I can say is that in our decision package that is in all of those options, 1, 2, and 3, that's what we have expressed. So we have expressed, we don't just want to bring CIE to a county. We want to make sure that there is interoperability between the different functions if we have multiple systems used across the state. It's a challenge. It makes it a more challenging way to go about this, but it's not unique to the IT world to take on those kind of challenges to work through interoperability. And of course, it certainly does help if regions agree to use a similar IT system to provide CIE functionality, because of course, then that's fewer linkages that we have to make. But I think it would be probably even more challenging for any organization to try to impose upon the state one way of doing things. So as much as there's risks in working through the interoperability and hiring IT expertise to make sure we can implement that, there would also be risks in saying, hey, you're all going to do it the same way. And because first of all, we know it's not going to work well in your counties in the same way it's going to work well for Puget Sound. So there's reasons for those differences. But we do see the functionality being similar, and we do see that there are probably reasons that there's probably possibilities of linking those systems together. And on the other side of it is we don't lose the money that we've already, in the time that we've already invested, around the state, and we can leverage that. So to stay on this system, Carol, I know your staff is quite familiar with this, and if you were just talking with the vendor ahead of time, I think some of these concepts are real familiar with everybody that you work with, and we're not even beholden to these bubbles. It's just that over time, because community information exchange was so new, we were asked several times, can you draw what you're talking about? Can you tell us what it is? And this is what we came forward with. Again, with the idea that we would have linkages between systems of similar functionality throughout the state.
Thank you, Michael. That's really a relief to hear that. So we've been working closely with 211. Skylar presented his app previous. So we just want to make sure that we're in sync and that we're not expending money that's going to have to be repurposed for some of the reasons. So thank you very much.
We did just have a question posed in the chat. Will a package asking for the funding include anything about expanding broadband for those that live in rural communities so they can be able to use the CIE?
Michael?
Very good point. Thank you. It will not. We have to draw boundaries around what we're asking for in a decision package, but more importantly, I think we are already working towards that with a Department of Commerce and other grants, and I think we would probably be best to continue on that path. And actually, just the way state budget requests work, if you put too many things into a decision package, sometimes it works against you. It kind of waters down the different concepts. But fortunately, I don't think we have to, because I think our requests for broadband have already begun. There's probably people who can, I'm just thinking of Russ Elliott from Department of Commerce and others who can speak to this. Jenny Harble from our agency, who's on top of broadband. But so there are a lot of efforts in that area, and they are needed as well.
Okay, and Michael, we've got another question about one of your bubbles. Could you expand on the assignment and attribution bubble?
I'll do my best. I will admit I'm probably a little bit better going right to left from 12 o'clock. But the attribution and assignment, that was a couple things. That was the concept that over time, there may actually be some form of groupings or paneling. And of course, as you probably noticed, as you go clockwise, starting at 12 o'clock, the closer and closer you get to community-based organizations linking with healthcare clinics and healthcare organizations. And so what we were contemplating is that since electronic health records are definitely an assignment and attribution system, that we would, to make true linkages, we would probably have to have some kind of an assignment or attribution system as well, the closer that we started tying into the clinical world. I have to admit, what we are attempting to do at Healthcare Authority is not trying to tie into the health care or clinical world from the get-go, simply because we think there's so much that can be done with closed loop referral, working with community-based organizations, which we feel like is the parts that have not been done today. So we probably have the biggest gains there. And I'd be glad to try for a follow-up, but I probably have colleagues that can do this better than I.
Okay, well, that was from Sam Wordle of our staff, Michael. So I'm sure that she can get back in touch with you. Do you have any other slides? We've got about 4 or 5 more minutes for your slot. So I thought you had another slide or two.
I think this was it. I tried to keep
okay.
it very simple today.
Okay. Well, then let's see if there's further questions from Michael Arnes on the perspective from the Healthcare Authority of CIEs. Are you surprised? Are you happy? What would you like to see? Well, Michael, maybe silence means assent, agreement. I know that just my sense of Greater Columbia staff is that we're very happy to see HCA grab this bull by the horns and hope that you will have some success with one of those 3 funding streams.
Thank you very much. And thanks for the invitation today.
All right. Well, thanks for coming. And at this point, we're going to take a 10-minute break, and then we'll come back with yet another case study. And this is looking at a CIE at a different perspective. And so you'll hear about that from Gina Morgan, but we will reconvene, let's say at 10:15. We're at 10:03 right now. So 10:15, we'll reconvene.
Thank you, Michael.
Thank you so much, Carol. Bye-bye.
Bye-bye.
Hello, everyone. This is Patrick again. We will start in 2 short minutes. So I hope you will all be tuned in at 10:15 so we can learn about what's happened in King County with community information exchanges. So stay tuned. We'll be right back. All right, I hope people are back, having been tanked up with whatever caffeinated beverage you want this morning. And we'd like to round out our presentations on community information exchanges with a view from King County, in particular the ACH that's in King County, Healthier Here. And we're going to hear from Gina Morgan, who I believe is Chief of Operations at Healthier Here. And in particular, we hope to learn how Healthier Here has thought about, navigated through the decisions on how a community information exchange might be governed and of course structured so it can be governed. And that will be something we'd hope to talk about once Gina completes her presentation. So Gina, I assume you're on the line. And
yes, I am.
It looks like we've got a lot of people back. So the floor is yours, and good. You've got the screen.
Great.
Or do we have the screen?
You all have the screen, which is fine.
Gina, are you muted? Are you ready to go?
I'm ready. Can you hear me?
Yep, we can hear you, Gina.
Dr. Jones, can you hear me?
Uh-oh.
I can hear you, Gina.
Okay. Hi, Carol.
Hi. I disembodied voice.
There we go.
Can you hear me, Dr. Jones?
I can.
Okay, great. I'm all set.
Okay.
And you all have the screen, which is fine. Thank you very much for those introductory comments. Pleasure to meet all of you. I believe I have spoken to this Leadership Council maybe a little like a year or more ago, probably about our community information exchange work, but I don't actually recall. Regardless, it's very nice to see some familiar faces and names in the audience, the virtual audience. A pleasure to be in front of the Greater Columbia ACH Leadership Council. So thank you for inviting me to join you today. If we can go to the next slide. One of the things I just wanted to start out by saying is our Cie Journey is it is in progress. This is not a fait accompli. This is a journey, and I'm going to share with you essentially a point in time of our journey that is evolving, and it's a journey that doesn't actually have a map. We are, whatever analogy you want to use, we are building the plane while flying it. We are creating the map while we are running the course. This is a work in progress. Not unlike all of you, we are the accountable community of health for the King County region. We are a nonprofit cross-sector partnership. We have a multi-sector board, just like the rest of you. And we have a role in our community that's probably looks familiar to you all, which is this focus on improving health equity and reducing disparities in our region by driving system change. In our community, we are a convener. We facilitate collaboration, and we, with our partners, are working in innovation to try to deliver care in a different way. So let's go to the next slide. So this should also look familiar to you all in the Greater Columbia region. This is essentially the system that is intended to support individuals and families with tremendous need in our community. And it is, as you can imagine, very difficult to navigate for these individuals. So essentially, we have been created to help figure out how we can collectively navigate through and create a system that is less fragmented, where individuals and families in our region can actually get to the care that they need in order to improve their lives and their well-being. So if we go to the next slide, this is the vision that our governing board created for our ACH in 2017. And it started for us, probably similar to all of you, with the Medicaid Transformation Project. And I think probably one of the most challenging things about a vision like this is, where do you start? How do you organize and orchestrate the work of things that have not been done before? So if you go to the next slide, for Healthier Here, part of the answer to how we accomplish our vision of integrated whole person care started with this understanding of community information exchange. And when I talk about community information exchange, which for us, we have branded through our community partners as the Connected Community Network. So now this is synonymous. We don't call it the King County CIE, we call it the Connected Community Network. This is not a magic bullet. We have learned that our CIE work is a tool, technology tool or a resource that helps to undergird the health and social care providers in our community. So that is really what we are trying to do, is we are trying to build an infrastructure, a technology infrastructure that undergirds the relationships that exist and need to exist more deeply between our health and social care providers. So let's go to the next slide. Our Cie journey began for us in the summer of 2018, when we began to convene our partners and stakeholders around aligning resources that were available in our community, and also trying to de-silo what we called mini CIEs. And when I say mini CIEs in our region, I'm talking about groups of organizations and providers that were exchanging information, for example, about a subpopulation. Maybe they're veterans, maybe they're older adults, maybe they're children. We had many CIEs, we have many CIEs in King County that are not currently connected to each other. So we really started to gain steam around our CIE planning efforts in late 2019 and early 2020. You might remember, or you might have been around to hear that Kaiser Permanente of Washington announced their partnership with Unite Us, and their plans were to roll out in King, Pierce, and Snohomish counties in 2020. At Healthier Here, we hit a blip with our CIE planning, this thing called the COVID-19 pandemic that really affected our planning efforts during the first 4 months of the pandemic, as our providers were necessarily called away to respond to that crisis. But momentum began building again last summer. When we reconstituted, we actually discussed with our partners, where does CIE fit within your sense of priority given everything else going on. I think what we heard overwhelmingly is if we had had a CIE in King County that was operational during the pandemic, it would have really helped to support how our providers were able to connect to clients and deliver care during the pandemic. So we reconvened last summer in a virtual environment, and it has been going very strong from a planning perspective over the last 15 months. And I would actually say that as a result of convening in a virtual environment, we have been able to gain participation from organizations that might have been hindered because a lot of our convenings, as you can see, at that time were in person. So we are convening in a virtual environment. We've had over 170 clinical and community organizations in King County that have been involved in various aspects of our planning over the past 15 months. We are doing a variety of monthly convenings with our partners. There has been a lot of activity around our CIE work regarding the planning over the past 15 months. The other thing I just wanted to, actually, before we go to that slide, the other thing I just wanted to address, and I was listening into the conversation prior with Michael Arness, is from our perspective, CIE actually is meant to cross both clinical, behavioral health, social service providers, and community-based organizations. That is what we're trying to build, an interconnected system across sectors, not just connecting CBOs. And I can delve into kind of the rationale and thinking behind that a little bit later, but just wanted to have folks understand that for our region, we're really trying to be truly cross-sector across healthcare and social care with our vision for community information exchange. So now let's go to the next slide. During the last 15 months of Fast and Furious planning, essentially this is what we have learned and heard from our community. This is essentially an evolving community of our community understanding of our region's needs. So it's not that we came out with a blueprint and people told us exactly what they need. It's really through the past 15 months of planning, this has been an evolving understanding on all participants, not just Healthier Here, but all those who are involved. And when I talk about listening to our community, I just want to emphasize the fact that this can't be lip service. We are trying to build a coalition of the willing. And so as a result of that coalition of the willing, because we want all organizations to want to participate and be able to participate, we can't be driven by Healthier Here's agenda, any other provider's agenda, any powerful players in our region's agenda, any technology company's agenda, or even a state agenda. It really needs to be kind of building it from the ground up. Coalition of the willing. That is what we're trying to build. So what we have heard from our community, we are wanting to build a unified network. We were talking prior with Michael Arness about interoperability. We are trying to build a unified network of platforms that connect, communicate, and cooperate with one another. We are focusing on being community driven and equity focused, not product focused. This is not about implementing one technology to rule them all in King County. It is about connecting technologies. Co-design has been critical to the work that we're doing. Our governance structure, which I'll go into a little bit further, is really community-led and operated. And you'll see through some of my examples what that means for us. And lastly, and probably most importantly, this has to be built, the network itself has to be built on the trust that providers have with each other and the trust that they have with community providers in the region and the trust that our community members have in participating in community information exchange. So let's go to the next slide. So what does building unified network mean for us? This is kind of our 4 legs of the connected community network stool. I'm not really going to go into a whole lot of detail into these 4 buckets, but I will spend a little bit of extra time on the one that deals with governance. and then I'll also talk about some of the other areas just to give you a little bit of flavor about what that looks like. So starting with the upper left hand, the governance structure, as I have mentioned and emphasized, this is a community-led governance structure. To the right, purple category is what does community engagement and consumer or stakeholder engagement look like? That has been an important element of what we're trying to build. Bottom left, that's really sort of the technology bucket, the infrastructure, the standards that allow for interoperability, and we have a vision for that. And then lastly, bottom right is around data and how we're able to leverage the data that comes out of the community information exchange for advocacy around awareness and knowledge of resource gaps in our region and what we can be doing collectively to bring greater resources to those parts of our community that are lacking in resources. This is what the vision for what community information exchange means for us with the Connected Community Network. And as I referenced before, back up for a second, as I referenced before, we are at the beginning or near the beginning of this journey. We don't know where it will go. There's no map to follow. And based on some of the sort of the conversations we've been having with other communities across the country, we understand that this is much the same in other regions as well, other communities as well. There is no roadmap. There are some communities that may be further ahead. They have implemented different kinds of models. I think that's part of what this is about, is what is the model that makes sense for your community? This is what we are discovering is the model that makes sense based on certain principles for our community. So let's go to the next slide. So starting with that governance leg of the stool, this is what we had created thus far for our governance structure for the CIE. We have an advisory group, and I'll go into a little bit further detail in terms of what that advisory group looks like. But the advisory group is the sort of the cross-sector decision-making body for decisions regarding the community information exchange. We have a network partner work group that meets monthly. These are the users of the system that understand their organization's needs and how they would implement and roll out within their organization, how they would operationalize, connecting to what it's going to take from a workflow perspective, really the users of the system. We have reached into our community to ask for individuals within their organizations that have legal, data, and technology expertise, and convene the LDT work group on a monthly basis to really wrestle with some of the finer details of privacy and technology. We also have the Unite Washington work group that sits underneath our Connected Community Network infrastructure. And essentially, as I referenced last summer, Unitas rolled out in King, Pierce, and Snohomish counties. I understand they're also rolling out in other regions of Washington state as well. And in our region, we requested and worked with Kaiser Permanente Washington and Unitas that in King County, to avoid confusion, that if the Unitas work group could sit underneath our governance structure, and we would help co-facilitate, co-lead those work group meetings with Unitas to be able to respond to those organizations in King County that are using and implementing Unitas, to have a place for them to come together and work out some of the finer details and challenges around maybe what their organizations are doing or trying to do with the Unitas technology. And then finally, we have sort of a placeholder for other work groups as needed that may be focusing on policy area, population type, a service type. We're actually currently working on some use cases. So the use cases might fall under these work groups. We've kind of left that as a placeholder. Next slide, please. So delving into our advisory group composition, you'll see that we have approximately 24 member currently governing body, the advisory group for our CIE. Maybe it looks kind of similar to the your ACH's governing board. It looks similar to our governing board. Our advisory group sits underneath the ACH governance structure in our region, you know, essentially is a work stream underneath our ACH. Our governing board for Healthier Here allocates MTP resources towards this work. The advisory group is essentially working on sort of the finer details of implementation, decision-making around the CIE. Next slide. So as I mentioned, the community and consumer engagement work, this is, I would say, one of our newest areas that is evolving. And I think as a result, as I had referenced, listening to our community, what does CIE mean? For us, it has meant engaging directly with consumers. And we have been implementing a model where we are funding our community partners who have our direct service providers to interview community members around, you know, what they see as the benefits of CIE. What would cause them to engage? What are their concerns with having their data shared? What do we need to accommodate or account for in terms of allowing or enabling community members to participate fully and understand what they're participating in when they sign on to being in our CIE. So we have community organizations that are leading this work. We are actively doing interviews with community members, and we, through our data analytics partnership with our local health department, they will be looking at that data and will be compiling a sort of a report synopsis in October for us to share and to inform our planning around the CIE work. The accessibility assessment is something that we weren't necessarily planning from the get-go, but this is, we have learned, is important to our the participants, the organizations that are involved in our CIE. That's related to, currently is related to language accessibility. In other words, you know, what language is the CIE going to be built on? What language is it going to be available in, so that our providers of multiple language groups can participate in the CIE, be able to have input and receive information on that CIE. Also, disability justice is another area that is evolving, that we are trying to understand better. What would make the CIE more accessible to the broadest range of community members in King County? Let's go on to the next slide. So around the technology area, and I'm not going to go into a lot around the technology area, but I did wanted to underscore this notion of protecting and maintaining privacy. And we have been putting together a privacy framework. Actually, in the past, our two past advisory group meetings, we had the documents on the right-hand side. Two of them are focused on consumer-facing privacy, and three of them are focused on organization, participant organization privacy. But we've had these approved working documents around our privacy framework approved by our advisory group. And if you go to the next slide, it illustrates what our privacy framework has been about. It's really been, it's been about 12 months in the works, design and iteration amongst our the community organizations that form sort of the center of the network, connecting with community members and experts in the field to iterate and develop these privacy principles and privacy documents. Most of the groups that have been involved have been consulted multiple times. As you can see, amongst the community members, we have had a focus on certain populations, immigrant and refugee populations, veterans, substance use disorder, older adults, Indigenous perspectives. Amongst the community organizations, this has really happened through our governance structure, our LDT work group, our network partner work group, and then Healthier Here through our ACH structure has an Indigenous Nations Committee that we have consulted with, as well as through our advisory group structure that has been the ultimate sort of approver of these of the privacy framework. And then the experts, we have been consulting with tribal data sovereignty experts, legal counsel, especially those that have expertise in federal and state privacy law, and then tribal law, and then plain language, especially for the consumer-facing documents. Next slide. So this is our version. Michael was sharing his, I think we call it the bubble slide, the 14 bubbles in the circle. This is our version of that slide. And essentially part of our 15-month process of listening to our community has been around understanding what the priorities based on community input are of CIE functionality. And this is essentially what we had heard. This is sort of a continuum from left to right, starting with a resource database and bidirectional referrals. We are working avidly on those two areas, as well as the data integration and interoperability priorities. As I had referenced, Unitas is in our region, the technology that upon which the bidirectional referrals is based. And we're also working closely with our local 211 provider, Crisis Connections, on the resource database work. We're also we're aspiring towards having a way to incorporate care team information. And then future work will be around a single longitudinal record for individuals, client access, and shared care planning being sort of the gold standard for what we would hope to build in our community. Next slide. The technology infrastructure that we are seeking to build is around this unified network infrastructure. So it's the boxes on the left-hand side. We actually have an RFP out currently. We have a number of bidders that are actively working on their proposals to essentially to help us build shared access and shared data under this unified network infrastructure, where we would have client index, resource database, care team information, longitudinal record information over time. And on the right-hand side, you'll see that the idea is being able to, in our region, connect different technology platforms, the purple and the green, into this unified network infrastructure for sort of a interoperable or integrated community information exchange for our region. Next slide. So finally, again, this is the data and evaluation, as I had referenced before. This is where we can really leverage the data that becomes available through our CIE to advocate for systems change and resources in our community. Right now, we've had a strong focus on tribal data sovereignty and making sure that tribes and tribal members, that we're accounting for the needs of tribes in terms of the way that we gather the data. We have also been engaging our community and stakeholders in an evaluation plan. We are intending to kind of in a continuous improvement framework, develop some evaluation measures that that is important to our community members and stakeholders to understand how effective the CIE is and how it needs to evolve and change to better address the needs of our community as it goes forward. So that is work that is also underway. So last slide before, next slide, which is my last slide before discussion. Next slide. What we have learned, like I said, this is a journey. We are at the beginning of this journey. The values of our community information exchange, they need to be shared at all levels from, from the ACH and our governance, our governing structures down to the community, the provider community and community member levels. The work is ongoing. It takes time. As I mentioned, the iterative nature of this work. We don't know all that needs to be accounted for. We are learning as we go. Technology is the enabler. It's not the end goal. Our work really needs to be built on relationships and trust. We've had a very strong focus on that in our work group meetings around building relationships and connections, especially during COVID times between organizations, to help build relationships and trust. And that community engagement is critical to privacy and data governance design. So with that, let me actually let's just maybe stop here on this slide, and I'll just ask if there are any questions or clarifying questions regarding what I've shared so far.
Gina, this is Carol. First of all, thank you for sharing this information with us. It's just so helpful to have a path to follow. You guys have, started that path, and we're just so eager to learn about your experiences. I did have a question about that bidirectional integration piece. So with that Unitas platform, does that build in those privacy agreements and those memorandums of understanding, or are there separate MOUs that organizations still have to have with each other in order to be able to share that data or those referrals?
Yeah, that's a complicated question, Carol. So I think the easiest way to describe this is to say that we are developing our community-driven data and privacy standards with our community. And those standards will be essentially, as we run through our RFP process for those bidders, essentially we are developing the standards which the bidders need to accommodate. We are putting the stake in the ground around what our community needs are. And the technologies, so Unitas technology is a bidirectional referral technology. We've supported it through, we had something called the Catalyst Fund that we ran last year to support organizations in King County to sign on to trying out bidirectional referrals, getting some experience and exposure to that. And we'll see how it goes. I think that's, it's essentially, it's for those technology companies that are going to be a part of our unified network infrastructure. It's really going to be a matter of their ability to accommodate what the community-driven standards are, what the community-driven privacy and data standards are. So that's a TBD.
Hey Gina, this is Diane.
Hi.
Halo from Greater Columbia. I had a question. So on one of the technologies that are feeding into the main, is collective medical one of them?
So let me just be clear. The technology platforms that connect the unified network infrastructure has not been built yet. There are no technologies that connect into our unified network infrastructure at this point. That'll be work that happens probably in 2022 as we work with our community to prioritize those technology platforms that that will be sort of go first integration targets into the unified network infrastructure.
Okay. Thank you.
But ideally, yes, I would say, Diane, given the work that we have, a different work stream within Healthier Here has been around collective medical. Ideally, we would see that being a part of, connected into the unified network infrastructure that we're building.
Great, because we at Greater Columbia, we have really stressed the importance of our partners using that platform. So it would be really good to have that one be one that would be fed into it. Thank you.
You're welcome.
Gina, I wanted to ask another question. So now that I have you here,
yes.
How many staff are working on this particular project. As we gear up to look ahead in 2022, we've set some funding aside to create a governance structure, but what are we really looking at in terms of staff time and staff commitment?
The CIE team currently has 4 staff members, not including me, because I spend part of my time on it, but I have other responsibilities as well. But I sort of lead and sort of the executive sponsor for our CIE work. But we have 4 full-time staff, an associate director for CIE, a project manager for the work that leads a lot of our currently the technology related work. And then we have a community engagement manager who is helping us connect directly with community organizations as well as consumers. And finally, we have a network manager who's helping to support organizations that are using the Unitas platform and working very closely with Unitas on our Catalyst Fund implementation. And then we have a number of consultants that we have tapped into around technology, around legal advice, even around communications.
Thank you.
Thank you, Gina. This is Patrick again. So I'd like to hear some questions from the group. And in particular, is this something, just to kind of repeat of some of the questions posed in the questionnaire or survey last April, is this something you would like to see in the Greater Columbia's 9 counties of efforts? And this would be helpful to help guide the ACH in 2022 and 2023, because right now I think everyone on staff and we think the board, not sure, thinks this is a good path to go. But do you see this helping your work in your organizations in the future? Anybody want to take that question up?
Hi, this is Melissa Haney from Optum Care Network Northwest. I just had a comment to make. So we are also one of the funders and supporters of Unite Us. And I just wanted to speak as kind of a larger healthcare organization that's across multiple regions with multiple payers that we're at risk for, that it's been so incredibly helpful to have a social determinant of health and care coordination platform that does span across multiple regions and can be used for any patient regardless of their insurance type. And, we've really appreciated Healthier Here's support that they have put into the utilization and the number of community-based organizations that have joined as a result of that support. So I just wanted to share that real quick.
Okay. And Melissa, for everybody's edification, your organization is what?
Optum Care Northwest. Yeah, we're both on the west side and on the east side of the state now, and we're made up of independent physicians in multiple counties, as well as the Everett Clinic and the Poly Clinic in Snohomish, Whatcom, Pierce, and King.
Okay, thank you.
Thank you.
So
thanks, Melissa.
So any thoughts from the group about how the Healthier Here's experience can inform our work in the 9 counties of Greater Columbia?
Actually, if you don't mind going to the next slide.
We're not done yet. There you go.
No, but we are, but we're not. This was sort of like, this was my framing of questions back to you all. How is your ACH thinking about collaborating through technology across health and social care sectors to better address the needs of individuals?
Right. Well, I think you've heard some of that from staff, but let's see if there's somebody in the non-staff in this meeting who would like to respond to that.
can I probe it? Maybe we could hear from some of our local health improvement networks. Maybe this is we can maybe include them as part of this and helping us get more social service sectors or more community-based organizations involved in it and using our local health improvement networks.
Right. Yeah, Diane, that's absolutely correct. We have talked about asking the LINs whether they would be not only participants, but actually leaders in this process that you've seen here from the King County area of community engagement. Is that something those of you on the call from the LINs feel would work for your particular groups? Anybody from the LINs would like to step forward and be brave?
You know you're out there. I see Kirk and Robin and
so let me
Mr.
maybe,
Rogers.
Let me be a little bit provocative here, if you don't mind. So, you know, I have spoken to a number of ACHs around Washington, and I think, and not just in Washington, but I've been hearing from other parts of the country that, how do we say, this is a very active space. Community information exchange is a very active space right now. And there is money to be made, stakes in the ground to be placed. I think your region should be asking who should be driving the bus. My understanding is that there are, technologies being rolled out in different parts of our state. Who should be driving the bus in terms of the technologies that get implemented? And what is the risk of not doing this in terms of continuing to de-silo efforts and technologies across the state of Washington? So that is the question that we have been asking ourselves, whether it be the ACH in your region or another community convener. I'm all in favor of ACH doing this work. I think it's a natural convener for this type of CIE work. And the risk is that it gets driven elsewhere in a way that might not be as community centered and might not be as cross-sector oriented. So that's maybe a different, more provocative framing of the same question.
So maybe I can be a little more provocative as well. Is this something that folks on the line think the ACH should, the Greater Columbia ACH at least, should tackle?
This is Dan. Can you hear me?
Yes, we can.
Hi, Gina.
Hi, Dan.
Thanks for doing the presentation. Representing the Yakima County Healthcare Coalition, I think we're really interested. I think we're particularly interested with the ACH kind of leading or being a catalyst for encouraging discussion and kind of understanding the value proposition for embracing this. So I think we will be adding this to our conversations at our coalition meetings.
Thank you, Dan. So that's a perspective from Yakima. Perspectives from anywhere else in the Greater Columbia geography. Kirk, I may call on you because you were brave enough to post something in the chat box. So would you like to elaborate on that?
I'll repeat it here. My concern is that we have enough trouble keeping 211 updated on the myriad changes and updates and changes in services and all of that in our community, and I expect that's true in most communities. What would make me think this is a better solution than what we're doing now?
Who wants to tackle that? that question from Kirk.
This is Melissa. I would be happy to answer that since our organization uses both. So I think the difference with Unite Us is funded by multiple larger healthcare systems. And because of that funding, it allows Unite Us to employ a number of different staff members that have active relationships with the community-based organizations that are a part of Unite Us. And so everything is kept up to date. In addition, it's a closed loop referral system. And so a patient, you can make sure a patient or a resident, depending on, client, depending on who you are, when they get referred over, the person who refers them over can see if they have actually been able to go through with that referral before. So I guess in short, there's a lot more funding and staff and support available to make sure that it works smoothly.
Okay, Kirk, further thoughts or comments?
I have a thought as well to share.
Okay, Gina.
So we have been working, in addition to with Unite Us, also with our 211 provider. Essentially what we're trying to do with our resource directory work, and as I had mentioned, I think it's going to be developed as part of our use case work, but essentially working with our 211 provider to, essentially to, how do I say, I think the vision of what we're trying to accomplish is not just having the updating of the resource directory be the responsibility of one organization. It really is about kind of ground truthing and having a way to keep resources up to date through sort of a community-driven process. And we're going to be ideally working with our 211 provider to be the convener around the resource directory work to try to navigate what does a decentralized, ground-truthed community resource directory look like? What does that process look like when various providers are updating and we're trying to kind of reconcile different records? What does that look like in our connected community network when we do that? So that is the vision of what we're trying to do, in which case all contributions are going to be needed and valued, and we'll have to figure out how to sort of ground truth the potentially duplicate entries and so forth around that.
Thank you. In a nutshell, I think anything that will really improve the system is a step in the right direction, and we're certainly willing to be a partner at the table. But I think I personally would want to see it work better than what we have now.
Okay, thank you, Kirk. Your comments on the 211 referral system. Anybody else have questions, general questions, or want to respond to those three thoughts that Gina has posted on her last slide?
Gina, there was a question about SUD and privacy, HIPAA privacy concerns. Is that what your legal team is trying to figure out, how you share particular data without violating those privacy concerns?
Yeah, that so I would say not just our legal team. It really has been working with our behavioral health and SUD providers in the region to understand what their requirements are and what it would take to for them to participate, given privacy requirements and so forth. So essentially, and our technology experts could speak more proficiently on this topic, but essentially, we are holding the network, and the network has agreed to hold itself to the highest standards to be most inclusive of all the different kinds of providers who want to participate in the network. So what this means is we're not building a database that everyone has access to. It's really more on sort of a by request only, and it's referrals between providers that are compliant. This is part of what the privacy framework work has been all about, is really clarifying what our partners need to participate, and then working with legal experts who are familiar with federal and state privacy laws, as well as tribal data sovereignty issues, to figure out how to accommodate within the network those needs.
That's helpful. Thank you.
Okay, more questions of Gina, or just general thoughts about a CIE in Greater Columbia? While people are pondering that one, I've got a question for Gina. I just wonder, Gina, why the particular groups that you listed in one of your prior slides were the ones chosen to start your community outreach and engagement with? Was it because they were the most organized, or was it because they were the most in need, or
yes,
what?
Yes.
Okay.
Well, there was some reference earlier with Skylar's presentation. When we started doing this work, we were starting to look for where is their expertise elsewhere in the country, whose shoulders can we stand upon to try to figure out how we're going to implement this work. And we discovered San Diego 211 and their CIE work. So the work group infrastructure we created actually is based off of their toolkit and what they had modeled. And I think we are discovering there are some other work groups that will probably be needed as we go, but we used their governance structure as a starting point for the creation of ours.
Okay. But in particular, you said you have seniors, vets, American Indian, Alaska Natives, immigrants, refugees, SUD groups that you have especially worked with. Is that not correct?
That was, I believe that slide was related to, I mean, essentially we are working across all the different populations that our providers are focused on. I would also say that, again, as I had talked about at the very beginning, back in 2018, when we were looking to align resources, one of those resources was related to a levy funding in King County that we applied for and received funding through the King County Vets, Seniors, and Human Services Levy. So that has actually been a series of focus populations for us based on those levy dollars, but it's not all inclusive, because we know, for example, through COVID, what some of the disproportionately impacted populations are in our region. So we've really cast a broad net at this stage around inclusivity of different kinds of populations. The use case work that I have referenced, that is going to be where we attempt to focus in a little bit on some priority work streams, some potentially priority populations that are sort of community driven. But that'll be the work of the end of this year into next year, in terms of how might we kind of get a lift around an implementation. Again, our unified network infrastructure is in the process of being built, but once we have that built, how might we use our use cases that have been identified and prioritized by our partners to, for instance, think about which technologies get integrated in first to address a certain population, perhaps, or a certain region of King County. So that's where our use case work is taking us.
Okay.
Hey, Patrick, there's a comment in the chat.
I saw that. Yeah. Maybe Tara, is it Terry Jane? Terry Jane, you'd like to just raise your hand and just say out loud what you wrote.
Hi. So I just wanted to say thank you. This has felt a little bit daunting at first when I was listening to it, like, oh, that'd be a great resource, but I don't know how well that's going to apply to us as a primary care practice. But the more that these presentations have gone on, I can definitely see ways that we can contribute and ways that this is going to be a tremendous resource. So I wanted to say thank you, and I appreciate that. And then there was a question that you guys were provocatively asking the group, saying, hey, can we see if there was a way that Greater Columbia could step in? And I definitely am giving you guys full thumbs up. I love working with Greater Columbia, and you guys help us to understand what the next steps should be. So that would be really helpful, although I have no real role in which to give that opinion. So thank you.
Thank you, Terry Jane. And what group are you with, just for everybody's?
We're with Police Medical in Pullman.
Okay. In Pullman, okay.
And so we're a multi-specialty practice.
Very good, very good. All right.
If I could just comment on that,
sure.
Just kind of as a closing comment. My slogan has been, we, as in the collective we are the C in the CIE, meaning we are the community that needs to own and operate community information exchange. And I mean, when I say I mean all of the people on this call. It really is. It's not going to be done or driven by one organization or one small group of organizations. It's really about how do we collectively create community in the community information exchange.
Well, that's going to be actually a very good closing note, Gina. So it's kind of hard to follow up on that one with any specific questions. So here we are. We're a little ahead of the agenda, but I hope we've had a pretty good idea of how we might proceed based on the three presentations you've heard here, and in particular what King County has done. So I guess speaking on behalf of staff, I guess I'll just ask one more time, how should we proceed? Well, first of all, I guess the question is, should we proceed? And then if it's a yes, then how should we proceed? And perhaps you don't have particular thoughts about that now, but I think I'll just say for staff that we would like to hear relatively soon whether those answer to the question. We've heard from Dan, we've heard from Pullman, we heard a little bit from the Tri-Cities, but we'd like to hear from others. So, because if we do this, this is going to be a major initiative of Greater Columbia's ACH. So, any quick comments from all of you about this particular part of our roadmap?
Well, Patrick, I can say that we definitely have this on our radar for Greater Columbia, starting in 2021, trying to figure out what that plan is going to look like. We've set aside quite a bit of money, a chunk of change, to be able to implement such a governance structure. I think our initial thought, and Diane kind of alluded to this earlier, was really leaning into the local health improvement networks that we have scattered across our 9-county region to help us determine what this governance structure should look like and what services need to be included, what organizations. So I wouldn't be surprised that there's something in their contracts after we talk to them about this a little bit more to help us figure this out, because the whole reason that we set up the local health improvement networks is they're the boots on the ground. They know the resources in their community. They know the difficulties of trying to get connected with each other. And so I think at first, an initial idea was to lean into the local health improvement networks and see if they couldn't help us figure this out. But we have set aside quite a bit of money for participation in a CIE.
Okay.
Yeah, so this is Diane again, and it's definitely going to take all of us. I think that we need everybody, and our ACH is so broad and so big that we're definitely going to need to rely on our local health improvement networks. But we would also like to, develop a subcommittee of this governance structure so that we can come together and really map out what we are really looking for, kind of like what Gina and her team had done. That way we definitely have the input from our community and our providers that are part of it. So will be more to come on that, but we will definitely be taking input from you guys.
Okay, I think we're sort of at the conclusion of our session, and I'll just entertain any final comments. Oh yes, as a reminder, don't forget the survey. We always like that feedback. And Gina, thank you again for that very helpful, detailed explanation of your journey with the CIE in King County. Skylar, I think you're still on the line. Thank you for your presentation and how you've done this as well. And I'm sure you'll be hearing from Greater Columbia ACH in the near future. And I just wanted to let you, that's a nice segue by Carol, because our next Leadership Council meeting, October 21st, will be all about the LHINs and what is going with those boots on the ground throughout the 9 counties. So I think this will be our third ever presentation like this in an October meeting. And they've always, I think, been very informative and in fact, inspiring. So don't miss October 21st. And as you see here, don't forget the survey as well. So with that, enjoy sunny skies before those clouds come in. And we will see you all at the latest in a month. We are adjourned.
Thank you.
Thank you everyone for coming.